So across New Zealand we've got a special interest group within the Paediatric Society for Paediatric Allergy, which includes paediatricians from Whangarei through to Invercargill. And a couple of years ago we wrote a sort of a summary really about an approach to diagnosis and management really related to New Zealand in terms of what's available. So that's just, it is there, it's easily findable. I won't talk so much about the epidemiology, but really about sort of diagnosis history, investigations, management. I won't talk about the prevention, but a little bit about future directions. So moving straight to diagnosis, and look, the key thing is the history, and the history is pretty much always trumps. This is out of a Gideon Lack paper from the New England Journal in 2008, but there's another couple of tables in other papers, and there's a really nice section in Up to Date. I don't know how many of you use that. Just really about how to think about what are the bits that you need to know, because I think that's where largely the answer is. What's the suspected food? You know, milk, egg, peanut make up 75% of what everyone sees. You put in nuts, fish, shellfish, kiwi fruit, sesame, and a little bit of soy and wheat, and that's largely it. You know, that's sort of 9 things that make up probably 95% of what we see. And there's a smattering of things that make up the rest of it, but it's the common stuff that occurs commonly. The question about was the food ingested, inhaled or touched is really important, because most systemic food allergic reactions occur from ingestion. Everyone knows somebody who reacts to the touch of peanuts, and I'll come back to it later. Touch reactions largely cause touch reactions. Inhalation does happen with some things, particularly stuff that gets really easily aerosolized, but mostly what we're thinking about is ingestion. The thing about aversion is that idea, you know, quite a lot of the kids, and young kids with egg allergy do the same thing. It's just impossible to get them to eat it. And you often say, so is there any family history of food allergy? No, but my mother kept trying to get me to eat egg, and I would vomit every time she tried it came near me, you know. So that aversion to things is important. That's not true if it's broccoli. How soon after exposure did symptoms occur? So IgE-mediated stuff is quick. Most reactions occur within minutes. Almost all reactions come on within a couple of hours, with some rare sort of exceptions to that. And how specific were the symptoms? So they're largely recognisable with some combination of the common IgE type things. How long did it take symptoms to resolve? If you've got urticaria, but your urticaria keeps happening, it's not a food. And so, you know, if you've eaten peanut on Monday and got urticaria on Monday, but you've still got urticaria on Friday, it's not going to be the peanut. Reproducibility is really important, because most food allergic reactions will follow suit to a certain degree. And exercise is particularly important as a cofactor with older patients, not so much in the littlies, but teenagers you start to see a bit of it. And you have this phenomenon of food-dependent exercise-related symptoms. And so you might be able to eat the food on its own, but if you have the food and exercise within a sort of a 2 to 4 hour window, then that gives you symptoms. And the Danish did this beautiful stuff. This is an aside, but anyway, they presented it at the allergy meeting recently, and so they took a group, and wheat's a really common trigger for this, and they showed that you were wheat allergic, but actually in isolation you needed this much wheat to cause a reaction, and it was something like 10 slices of bread that you wouldn't normally eat. But if you did it with exercise, then your threshold came down and you only needed a bit of wheat plus exercise. And if you did it with exercise and you took a non-steroidal, then your threshold came down even further. And if you did it with exercise and a non-steroidal and 2 glasses of wine, your threshold came down even further. So it's fantastic. We don't see that in paediatrics either. Not in the patients anyway. And then on, thinking a bit about testing as part of diagnosis. So, like I said, the common foods are common. Soy's always listed in that group of common foods, but we see very little soy allergy. I don't know, I reckon maybe 2 or 3 cases a year of proper soy allergy, even though it is in that list. And then when I looked back over 100 sequential patients, just out of my own interest, there was 1 each of buckwheat, haricot, navy bean, pumpkin seed, banana, mustard, potato, rye, oat. So you can be allergic to lots and lots and lots of stuff, but it's the common stuff that's common. And then when we're thinking about food allergy, I always need to think a bit about cross-reactivity, co-sensitivity, and then a bit about contamination. So this is from a relatively old paper, really looking at, if you're allergic to a legume, actually, mostly you're not allergic to other legumes. So peanuts are legume, but if you're peanut allergic, it's milk and egg are the ones that go commonly along with it. If you're allergic to tree nuts, then you've got a pretty high chance of being allergic to another tree nut. And then within that, there are patterns. So cashew and pistachio are quite common, and walnut and pecan are quite common. Fish and other fish is quite high, and one of the trouble with fish is that all of our skin prick testing stuff comes in from Europe, and so it's European fish species, and we don't have local fish commercial extracts for skin testing. Fish and shellfish, it's different between mollusks and crustacea. The crustacea is quite high within them. Grains and other grains is relatively uncommon, and then there are things like beef and milk. I think is actually pretty rare. Cow's milk and goat's milk is almost universal in kids, and so if you're allergic to cow's milk, you're going to be allergic to goat's milk, which is always quite good if someone comes in and they're allergic to cow's milk but they're on goat's milk. Horse's milk, not so common. And then these ones down the bottom are mostly what we call secondary food allergies. So in kids we mostly see primary food allergy, you're allergic to the food. In adults it's a phenomenon of where you get secondary food allergy as a kind of a consequence of being allergic to pollens. And you see it like in Europe with birch pollen, it's really, really common. They get a lot of fruit and vegetable stuff, so cherries and stone fruit and celery and apples, where you get oral itching, tingling, sometimes more severe food allergic reactions, and some of those patients will also have trouble with latex, but we don't see so much of that in kids. Mammalian milk cross-reactivity, so this is a blot of the proteins in milks, and so that's human milk in the first column, and you can see there's really nothing there that goes along with goat's milk, cow's milk, ewe's milk. This is buffalo milk, this is camel milk. And this is what camel milk infant formula sachets look like. But it's not readily available. I don't know what it tastes like. It's kind of revolting, but there you are. And then one of the other things we see with nut is, peanuts are legume, but if you are peanut allergic, you've definitely got a higher chance of being allergic to other nuts. And that's probably somewhere in the order of 25 to 50%. If you're allergic to a nut, you're most likely going to be allergic to more than one nut. If you've got peanut or nut, you've got about a 15% chance of sesame. If you've got peanut and nut, you've got about a 50% chance of sesame. So there must be some shared proteins in there somewhere. And then as well as, so all of those sort of reactions are cross-reactivity. They're related to similarities in the foods. But obviously milk, egg and peanut are not similar and go together as the commonest three food allergies. The top one is a Spanish study looking at 100 kids presenting with cow's milk allergy who had not yet had egg, and when they looked at testing and then challenging, 40 of the 100 were egg allergic as well. And I think the complexity of food allergy is probably different from when I trained, when we would have said most kids were allergic to one or two foods. This is late 90s, but even by then they had nearly 2% of kids were allergic to 5 different groups of foods. And so single food allergy is much less common than it used to be. Coming back to the route of exposure, almost everyone knows somebody who has had a reaction to the smell of peanut. And it's curious because actually it's very hard to make that happen in the laboratory. So they took a group of kids who were old enough to know they were allergic to peanuts, so median of 7 years. They were decently allergic. They had very high specific IgE on testing, a bit of asthma, eczema, other food allergy. Just on half of them reported previous contact reactions and about a third previous inhalation reactions. And what they did in the study was they put peanut on their back without them knowing whether it was peanut or something else. And then they aerosolized peanut but masked it with mint so they didn't know what they were smelling. And in fact, they couldn't cause anybody to have a reaction to inhalation in the study. Now, it doesn't mean it can't happen. It just means they tried and they couldn't make it happen. They did get local irritant reactions. You definitely do get significant reactions with things that are being actively aerosolized. So, if you walk into the house and fish is cooking, you can smell the fish. But if you walk into the house and someone's eating a peanut butter sandwich, I don't think you can normally smell it. So I think it depends on how active the process is. But I think it's quite reassuring to know this, because actually it means that you can say to parents, we don't want the child to eat it. We don't actually think that smelling it's likely to cause trouble. If you smell it and you don't like it, you can move away, but you don't have to worry that somebody else eating it is going to make you desperately sick. Other features, so like I said, normally come on pretty quickly, go away relatively quickly. I think, although food allergy isn't the cause of eczema, if you've had a food allergic reaction, you do sometimes get aggravation of eczema as part of that. The aversion we've covered in the cofactors. So in terms of the history, I think that's done, and really what we want to think about is the testing. I think signs and symptoms, and I went over these before in terms of manifestations. I think, there's still discussion about whether eczema may be non-IgE mediated related to food, but I think the data is pretty poor. Mostly what we're thinking about is the IgE mediated stuff. In terms of non-IgE mediated gut stuff, you can definitely get food protein intolerance where you get gut related symptoms with vomiting and diarrhoea, and little babies with a bit of blood in their poos, particularly related to maternal cow's milk ingestion. That stuff's difficult because there's no diagnostic test for it, so it is a matter of taking something out of the diet and putting it back in the diet. And I think the key to it is the putting it back into the diet. And I think if you've taken something out and you haven't got dramatic improvement, then it's not a question of taking something else out, it's a question of saying that's probably not what you're looking for. And again, just the lower respiratory signs and symptoms and cardiovascular involvement being anaphylaxis. So in terms of diagnosis, around the country, pretty much everyone has some access to skin prick testing in community labs, with a bit of variability about how readily available that is, what their protocols are in terms of age and what allergens they've got available. And then specific IgE, which has previously been referred to as RAST or EAST, but which is now largely called specific IgE, and a bit about which and why. And I think the first question, and this is the question that I often get from registrars in clinic, is, well, why do you bother testing? You know, you've got someone who come in, this is a real patient who was referred to clinic, he'd come into ED, he'd had a teaspoon of scrambled egg, and had relatively prompt onset of what was thought to be anaphylaxis, was seen in children's emergency at Starship, given some adrenaline, got better, and had a history that when he ate things like muffin or cake, he seemed to get perioral erythema and itch. So he sounded like he had egg allergy, pretty good story. And in clinic, he had a negative skin test, which I didn't really believe. So he had a blood test, which was also negative, and so he had another skin test, which was negative, and in fact we skin tested him with some fresh egg and it was negative. And he came back and had a challenge with a runny egg and he was completely tolerant. And I don't know what caused the anaphylaxis on the day. I think from memory, he was also positive on testing for peanut and wasn't thought to have eaten any peanut that day, but maybe he did. But it clearly wasn't the egg. Now, if we hadn't tested him, I would have said, you're egg allergic, you can't have egg in baking, which means that your chance of growing out of this by the age of 5 is probably about 30%. So you should avoid all egg. And that would have been wrong and quite difficult for him and for the family and pointless. So yeah, I think there is a point to testing, which is to confirm what we think we know. So in terms of what to test, the first thing I would say is I don't think any lab should be offering a food panel, a group of foods that they test on everybody who needs allergy testing. And the Auckland lab does offer a panel, but what I say to people is don't ask for it, just write down the ones that you want tested. The ones that people are eating happily you don't want tested, because if you get a positive it can sometimes be very hard to ignore. So write down what you want. Thinking about other allergens, because the story is the most important thing, and you don't want to test the things they can eat. Beyond that, it depends. I think on a purist level you can say, well, you shouldn't test other things because the best thing to do is to eat them. And in one way that's true, but for some families their experience is that that's a very difficult message. And if you've already had significant allergic reactions to 2 or 3 things, telling them to go home and eat other things where there might be a 30 or 40% chance of another food allergic reaction is something that they just can't do. And so I think that whether you test other stuff really depends on what's happened up to date and how the family feel about the chance of having another food allergic reaction that they're going to have to manage. I think if you're going to test things that that kids haven't eaten though, we really need to be able to think about how you're going to manage that, because you have to have some access to supervised challenge to decide whether or not those things are important or not. And if you've got no access to supervised challenge, then I think the best thing to do is to eat. And if tests are negative, then that little box should be an arrow saying that the food should be introduced, because your testing's only really relevant for the time at which you're doing the testing. Food allergy in kids is not a fixed phenomenon. You can develop new stuff, and so you can't say, well, I had a negative skin test to peanut a year ago, so now I'm okay to introduce peanut. You might be and you might not be, and things change. So if you're using testing to help you liberalise a diet, it's only relevant for the time at which you do it. In terms of testing, if you're looking at reports, you need a positive control, you need a negative control. You can test for a wide range of things, so that a lot of the community labs will have a relatively limited range of options, but certainly locally or in Wellington and Christchurch, the hospital lab has a broader range of things that are potentially available. And it's pretty safe and easy to do. You can't do it if you've got bad eczema, because you can't really see what you're doing. And you shouldn't do it if someone's actively wheezy. And 3 millimetres is by definition a positive test. So it doesn't matter what the ratio is between the test and the histamine, and 3 millimetres by definition is positive. This is a ROC curve of the skin testing data out of the Health Nut study. And just as a reminder, for people who don't look at these very often like me, that what you want is that the curve comes up as close as possible to this corner, because what that means is that you've got really good sensitivity and specificity. You're not going to get false positives and not false negatives. And so you've got peanut in the blue, sesame in the green, egg in the red, and they're not bad. They're getting up quite close to that corner. This orange line is the baked egg, and so what you'd say about that is that really you probably may as well toss a coin to work out whether or not baked egg is going to be tolerated. You can't really use your skin test to work that out. And this is the same data but just presented in another way. And what they've done here is created a 95% positive predictive value, which is the proportion who've got a positive test who've got the condition. So once your peanut got to 8 millimetres, 95% of the kids at 8 millimetres or more were actually allergic on challenge. With egg, once you got to 4 millimetres, it was 95%. With baked egg, at 11 millimetres, you only had an 82% positive predictive value. So if you used 11 millimetres as your cutoff, you're potentially labelling 18% of the kids as allergic to baked egg, even though they might actually be tolerant. And sesame was 8 millimetres. And so they've calculated negative predictive value, sensitivity, specificity, and also this thing over here called a likelihood ratio. And that's the probability that a test result is correct in proportion to the probability that the test result is incorrect. And I'll come back to why that's useful. But what they're saying is that using these cutoffs, you've got quite a good likelihood ratio for egg, peanut and sesame, but actually they couldn't calculate a good likelihood ratio for baked egg. So our testing isn't very good at predicting whether or not baked egg is going to be tolerant in those who are egg allergic. This is just to remind me to say that skin testing for wheat is actually really not that good. So this was a retrospective look at food challenges. They had 39 out of 94 wheat challengers who reacted. And these are the skin test sizes of those who were tolerant at challenge and reacted. So you had some with essentially pretty much negative skin tests who were allergic at challenge, and some who were tolerant with really pretty big skin tests. And so for whatever reason, wheat doesn't perform terribly well. The other way of testing is specific IgE, and so basically what you've got is you've got some sort of matrix that's got the allergen absorbed onto it. You add the patient's blood, which has got IgE directed against the allergen, and then you're adding something else that is directed against the IgE that's got a label on it that you can measure. So it used to be radioactive, which is why it was RASed, and it's now not, and which is why it's not anymore. And And you can basically measure the proportion, the amount of specific IgE in the patient's blood. We know that some allergens are not terribly stable, so particularly fruits and vegetables, so specific IgE is less sensitive for those patients. I think this is challenge data for 1-year-olds, really just showing the same sort of stuff that Katie's staff showed with skin testing in Melbourne. So this is milk-specific IgE, and what they're saying is that everyone with a specific IgE of over 50 to milk was allergic at challenge. This is egg down here, and this also is similar to the skin test stuff, so that actually relatively lower levels for egg are of equal significance. So almost everybody with an egg level of over 3.5 was allergic at challenge. And then this is soy and wheat, and both of those perform actually not very well with specific IgE. So really with wheat, we're a bit stuck that you can have quite high levels of IgE or a big skin test and not be allergic, but quite low levels or a negative skin test and be allergic.
When you get the results, do you usually get those norms? Like, do they? No, they don't.
Well, the trouble is it's very complicated because this is age and the influence of age, and so this is nearly 1,000 Japanese food challenges, that's egg and milk, and a level of 3 in an under 2-year-old is quite different to a level of 3 in an under 1-year-old, so in terms of what its prediction is. So there's a whole lot of things come into the mix, and it depends on the population that you've looked at as to exactly what those things mean as well. So, pros and cons. Look, I mean, I tend to do skin testing because I do it myself, and so I get an answer straight away, and it makes it much easier. Specific IgE takes time, and from a DHB point of view is expensive relatively. I think the key things about both of them is that if you've got really strongly positive results, either on skin testing or blood testing, it does up the chances that you're definitely allergic, with the caveat that some things like wheat don't perform terribly well. But importantly, neither of them are about predicting severity of allergic reaction, so they're just about whether or not you're likely to be allergic, whether it's confirming what you think you know. So there have been these sort of thresholds proposed in terms of what you were just asking about levels. The trouble is, I think they're only really relevant for the populations they've been studied in, and can't, you know, if you've done the study in a highly atopic group of patients, then your positive predictive value is going to perform much better than in a population where the prevalence is much lower. And not everyone has reported likelihood ratios, which is really a way of trying to generalise it to the population. But, you know, it gives you a ballpark idea about what do we think is high. And so for both skin testing and specific IgE, lower levels are probably of equal importance in younger kids than higher levels in older kids, both on skin testing and on specific IgE. This is my favourite bit about how to make sense of it, because it's really about using your pre-test probability, what you think the likelihood is before you do the test, and then the likelihood ratio from your test to get a post-test probability. And I'll show you what it means. So that if you had, say, this patient, 2 recent anaphylaxis to peanut, you know, eaten peanut twice and had immediate reactions, you can say the pre-test probability that this kid's peanut allergic is probably close to 100%. Their skin test is not very big, but because your pre-test probability is so high, even if your skin test is not very big, your post-test probability is really high. So you're not worried about the small skin test as being a marker that, well, maybe it's not true. No peanut ingestion, but a sibling with peanut allergy. I think I said this morning, you know, your pre-test probability is 7%, just because that's the population frequency. A specific IgE of 2 gives you, you know, it's not very high, it's not very low, it gives you a likelihood ratio of about 3. And post-test probability is relatively low. And so that's the sort of patient that I think you should challenge. But if you'd got that test result, that same test result with your previous patient, your post-test probability would have been really high because your history is really good. So it's taking the history in the results in the context of the history. Known cow's milk allergy, never had any peanut. Well, your pre-test probability is about 30%, just because that's about the frequency. a specific IgE of 35 gives you quite a high likelihood ratio, and so probably most of the time we wouldn't challenge that patient, we'd just tell them to avoid it. And we quite often get this where you accidentally get food allergens tested because somebody's ticked the box when actually what they were doing was trying to test for allergic rhinitis. And I know, but it happens all the time. And then they get rung up and say, oh, the peanut's positive, you should stop eating that. And, and you can have quite high test results, but if your pre-test probability is really nothing, then your post-test probability is nothing. So it's not just the test result, it's the story. And I think that's why it gets so complicated, because it's not tidy. I like tidy. So once you have made a diagnosis, then it's easy, I think. These were the referral guidelines that we came up with, and I think really what we're saying out of that New Zealand Medical Journal paper, paediatricians around the country want to see anyone who's had anaphylaxis, I think. I think where there's multiple food allergies, particularly if you've got critical foods like milk or wheat, you often do need dietetic assessment. It's quite hard to access that in the community. Where there's uncertainty about diagnosis or interpretations, if there is sensitisation that's been picked up on testing, but you think there's a reason to think about a supervised challenge, and probably peanuts and nuts because of the ongoing risk of severe allergic reactions. Asthma is one of the risk factors for more severe food allergic reactions, and I think within paediatrics we probably want to see kids who don't grow out of it. But I think there are kids with food allergy who should be looked after in primary care. And really the bits of management then are thinking about making the diagnosis, advising on avoidance, making sure there's an action plan, and then some sort of follow-up testing to see whether there's a chance that they've grown out of it and whether they can safely reintroduce it at home or need a supervised challenge at the hospital.